Alright, so test 2, Monday. Hopefully in our same computer lab, but they've been doing construction, so we might have to go to building 10. So definitely look for an announcement from me, just to be sure that we're going where we usually go. I sent an email today. I haven't heard back as to what the situation is for the computer lab that we're using in regards to that construction for the auditorium in building 1. I kind of peeked in there today, but I don't know what the heck's going on. So I hope to get an answer today. So look for a confirmation that we're going where we're supposed to go, or look to see if we're going right next door here to building 10 in the library classroom. Not in the library, but the classroom 134. So yeah, when you're coming from this side, right, down this walkway, and you enter into building 10 from the back way, it's literally right there on your right, the computer classroom there. So hopefully that's available if the other one's not. So I will find that out today. I'm actually heading back to building 10 for the workshop that I've been in this morning. So the other thing is that I had changed the date on that immunology bonus activity. I had hoped that I would look at it last night, but I've been busy doing the stuff for the training that I didn't know. And give us a lot of advance notice on this training. But that's okay. It's going to be good for my students. So I was really hoping to look at. But notice that you can still do that, y'all. I haven't graded that. I don't think it necessarily shuts down. When I put due dates, that's just when I really need you to have it done by. Unlike Connect, I think it doesn't let you do it past the due date. And as far as Connect goes, again, I was hoping to look at some of these web links that you guys are posting. That's still open until today. Yeah, because I was hoping I would look at that. But it's still open. If you guys want, I'll even change that due date to Monday's test. But really, at this point, you should have already done it, right? And if you haven't, make sure you do it. Any questions regarding those two things? Okay. Remember, Connect assignments, you got to do them, right? They're required part. They're in your best interest to study and then take it like a quiz. And remember, you can do it again until the deadline. So there's the last one for this last topic, disorders, that I added last night. So and I added the link, right to Connect for you guys to help remind you about that. So innate had 2 parts, right? And then we had adaptive and disorders. So not too many, right? Unlike Unit 1. You guys will hate me later. We got some more coming, but not too bad. So as that goes for our next unit, there are some topics that I'm not going to test you guys on, but I do need you to read and look at, especially before class, before this next unit. So I'll remind you guys the day of the test, but I know you guys are kind of, but I will post an announcement for this. That there's 2 chapters that I really want you to look at and answer questions on Connect before we get to the other chapters. Because this next half of the semester, we're going to focus on diseases, right? And certain things that relate to diseases, like antibiotics, right? I don't want you guys memorizing all that information, right? That won't do you any good, but I want you to be familiar with that information. So one of the ways to make sure that you've actually at least somewhat reviewed the material is to do a Connect assignment. Does that make sense to you guys? So although I won't lecture on it specifically, I'm going to refer to it as we talk about the diseases. And again, the nice thing is that, when you guys look at these disease chapters, there's a bunch of diseases, right? We're not going to cover them all in every chapter, right? We're going to do a select few, okay, that you'll need to learn and know about in detail, right? That's the rest of the semester is going to be all diseases, right? We're going to go by systems of the body. We're going to start out with skin, then we're going to go to wound, right? Respiratory, digestive, urogenital, and the STDs. Again, I usually don't cover that in class. I give you guys a Connect assignment, right? But again, because I don't cover it in class, I'm not going to test you on it. But you'll still have to do those assignments. So make sure if you haven't, get your assignments done, right? Do that bonus. I highly suggest watching those videos, right? Those are really excellent videos that of me teaching in class, if you haven't already watched them. You know, make sure that you contribute for that discussion board, right? Because it's 40 points. Make sure you post something and that you reply to 2 of your classmates. And then this was a while ago, but this is a good thing to even look at again, right? Those web pages. Read it again, right? It's a good review as we're coming up on the test. So that brings us to the last bit of disorders, right, that we have to go over. So we're on rejection of transplant tissues. So what molecules on our cells are responsible for most of the allograft rejections? This is transplanting from one person to another, an organ or tissue. So it has to do with communication in our cells, right? And how do our cells present antigen? What do they present it on? What type of molecules? It has an abbreviation, and there's 2 classes of them. MHC, right? MHC class 1, which is all of our cells, how they do antigen presentation, all our nucleated cells. And then MH2 is specifically for antigen presentation by our specialized antigen-presenting immune cells. Who are those cells? Who does antigen presentation? Dendritic cells are our main antigen presenters, right, to our T cells, right? They're going to activate our T cells. Who else can do it? B cells have to do it to communicate with T cells to get themselves activated, right? One more. Macrophages. And again, this is for getting themselves activated further by T cells, or even them themselves can activate T cells. Although that's the main job of your dendritic cells, right? Is that antigen presentation, activating T cells, whether it be helper T cells, right? And if they're communicating with helper T cells, it's MHC class 2, right? This is stuff they're engulfing, right? We're talking to the helper T cells, which who are they mainly going to help out? Who do they go and activate? The B cells and who else? Before you get to plasma cell, what cell differentiates into a plasma cell? B cell, right? So they communicate with those B cells, right? Those CD4 helper T cells communicate with MHC class 2 only, right? This is that very specialized antigen presentation that has to happen within our immune system, right, for making antibodies for that humoral, that antibody response, right, component of our adaptive immune. For your cytotoxic T cells, again, getting them activated, that would be the job of your dendritic cells. But that's a different MHC. That's MHC class 1, right? And so they would activate those guys. And cytotoxic T cells now are going to go out and hunt cells, any cell that's presenting MHC class 1, that particular antigen. Right? This is one of the major ways, right, that we defend against stuff that gets inside of our cells. Right? MHC class 1 is for stuff that gets inside of our cells. So these MHCs are very important for communication with our immune system, right? Communicating that the cell is okay, right? Everything is okay. So what cell will actually kill cells that aren't presenting MHC class 1 at all? Natural killer cells, right? So, you know, if we can't communicate with it, that's a serious problem. And that's why this was called major histocompatibility complex. Because it was these molecules that we found out later our immune system is using to communicate are the ones that create the serious problem when we do organ and tissue transplants. Because your MHC, that actual molecule you make to hold on to that antigen, is different from someone else's. And so the fact that it's different, your immune system can't communicate or recognize it, right? That processing that happens for your T cells in your thymus, right? That they're able to communicate with your MHC. Well, if you all of a sudden have these cells in your body, right, these organ cells that have a different MHC, your immune system, your T cells, right, can't communicate with these cells. And in fact, they see those cells as foreign, right? They don't know it's MHC. They see it as something different than our body. Because that's our major component of our T cells, is this recognition between self and non-self. Well, they see it as non-self and not being able to communicate with it. So they're going to attack it. So that's how they got this name, major histocompatibility complex. These were the major problems, right, when we try to do tissue and organ transplants. And the reason for that is the immune system does not recognize them as self, because they're not. They're foreign, right? And they can't communicate with them. So it's foreign. We're going to eliminate it. So that's why they try to match as close as they can. But even then, right, the only way you can get a perfect match is if you have an identical twin, right? Because genetically, you're exactly the same. How many of you guys got an identical twin out here? Fraternal's different, right? Fraternal doesn't count. Fraternal means you shared the womb at the same time, but you are two genetically different people, right? Two different eggs, two different sperm. Where with identical, it was the same sperm, the same egg, and it split at some point in development into two individuals. Fraternal just means you shared the womb at the same time. But you're two separate individuals. That's why you can have male and female fraternal twins, right? Where you can't for identical, because you literally are genetically identical. Make sense? Okay? So none of us have a spare parts friend out there, right? That would be the only person that could definitely give you a kidney, and you wouldn't have to worry about any miscommunication, because genetically you're the same. Okay? So, of course, close relatives, because again, your genetics determine how you make these molecules. So a close relative, a brother or sister, a mother or father, you know, things like that, usually are relatively close matches. But you're never going to get a perfect match unless it's an identical twin. Or a clone. God knows we're probably getting pretty close to that, right? You see those sci-fi movies where they're, you know, cloning people. It's pretty crazy stuff. What would happen if, all right, we're talking about not that perfect batch, right, but you've gotten a transplanted organ or tissue. What would happen if that person stopped taking immunosuppressant drugs? Right? So why are they taking those immunosuppressant drugs to begin with? Right, so the body does not attack that organ. Because, trust me, you're not getting an organ transplant just because. You're getting it because without it, you would die. Right? That's why when I said before about the spleen, right? That's the only one you can live without. They don't do spleen transplants, right? Because you don't have to have it. But heart, lung, kidneys, right, these type of things, you're not living without. Right? So you're getting this transplant to survive. So if your immune system attacks it and kills it, what's going to happen to you? You're going to die. So people who get organ transplants are on immunosuppressant drugs for the rest of their lives. Huh? Better than being dead, yeah. Better than being dead. And also those individuals, because of that, right, they're suppressing certain components of their immune system. So they're more susceptible to what? Diseases and infection, right? Trust me, none of them are working at a daycare. That's nothing but a bunch of little germ magnets running around. Right? They're not going to crowded festivals, right? You know, their lifestyle, depending on what it was before, may even significantly change because, right, they're at greater risk for infection.
So when you have a transplant, you have to stay on the
immunosuppressant drugs for the rest of your life. Yes.
So what about the person that gives
Right.
I have to.
No, well, you just gave it away, right? It's gone. If you gave away a kidney, it's gone. You didn't get anything foreign put in you, right? It's just gone.
Because I was just wondering if I would have to take something since
No.
I'm without.
No, no. In the case of kidneys, they're so important. I guess, you know, they gave us a spare. So you can survive with just one. It's not as good, right? But, you know, that's one. And livers, too. Like, people can donate part of your liver to someone else. And it can graft in and give them what they need. Like, they don't have to take the whole organ from people. So there's people that, you know, when you're still alive, right? Those are the 2 organ transplants that you could do to save someone else. Is a kidney. You could donate a kidney or a piece of your liver. Right? But other than that, all other organ transplants come from someone who's dead. Right? Someone who's dead. Make sense? Good questions. So, what antigens did we say are the ones that create this major problem? The major histocompatibility complex, right? And, right, we know now that it's part of the reasons they play a role in communication with our immune system. They're very vital to our adaptive immune response, this communication with T cells and B cells. So what cells then are responsible for all allograft rejections? So who has to communicate with MHC? T cells. T cells. T cells especially here, right? And it's going to be MHC class 1, right, that those cells are going to be expressing. So what cell is going to come by, not be able to communicate with them, and probably kill them? Natural killer cells, right, because they don't recognize the MHC for one. And then also which T cell communicates with MHC class 1? Cytotoxic T cells. Right? Your CD what? What are cytotoxic T cells? CD8, right? Think of EAT. So the major drawback to graft transplant is the possible immunorejection, right? The immune system not recognizing it, right? Because of course it's foreign. That's a major job of our adaptive immune response, is to recognize foreign stuff, right? This was not yours. You were not born with it. It is foreign. Right? So the differences between the donor and the recipient tissues are the basis for that rejection. Right? The fact that it's not a perfect match. And it's predominantly a type 4 hypersensitivity reaction. Because remember, type 4 is cell-mediated. T cells, again, T cells not recognizing or recognizing that it's foreign. So sensitized cytotoxic T cells, as those proteins are in our system that are expressed on those cells recognize it as non-self and start attacking. Natural killer cells, again, can't recognize that MHC, so it thinks it doesn't have it. So it's going to kill them. Combinations of different agents, right, are commonly given to, and I'm not going to have you guys memorize the drugs and stuff like that. But of course, they're ones that interfere with T cells, right, to keep them from killing off your graft or transplant. Now, I forget the name they give to. Now, xenografts is like where they give you from another animal, right? Which I think I was telling you guys they've been trying to engineer pigs so that their MHCs match people, and we could give them. Pigs are actually very close to us, believe it or not, genetically, very close to us. I know it seems kind of bizarre, but yeah, believe it or not, they're really close to us genetically. I think it actually really has been done in some instances, like with primates, even like baboon heart to a person. I know there was a movie years ago, but I think it really has happened for real. In some cases, they've done that. And then some people, like especially when it comes to skin and stuff like that, like my husband even had a skin graft, you know, where they took from one part of his body to another part of his body for a wound. So he had a real serious injury, got all the way infected to the bone, and they had to go in and scrape, and it was a mess. And they couldn't seal it back up, so they had to take a graft from one part of his leg, from one leg to the other leg. And he's got this big, huge scar, an indentation in his calf. So I always joke with my friends and say they get bit by a shark, because, you know, that's much cooler than what actually really happened. But again, didn't go to the hospital, right? Didn't seek medical treatment for about a month. His mom was a nurse even. She took a look at his leg and she's like, oh my God, you need to go to the emergency room now. And the infection had spread all the way to his blood. I mean, all the way to his bone. So he had to be on IV antibiotics for like a month. And had to have major surgery and plastic surgery, you know, to repair that. So, it's, you know, when you have injuries, don't let them go, right? Go. He won't ever do that again. He almost died. How do what? Maggots. Oh, yeah, that's an interesting one. So the problem, and we'll talk about it as we start getting into infections, especially wound infections, this next unit we've got coming up after. But the problem, and remember I said, what's our primary immune response? What needs to happen when we have tissue damage, inflammation? You guys have got it, yay. My other class is just starting on this unit. I'm like, yo, listen, when I say primary immune response, inflammation is what you say back to me, right? So you guys have got it. So what is that, though? That's influx of the white blood cells, right? The ones that actually do all this wonderful stuff. Well, when you have tissue damage, do you think blood vessels are damaged too? Yeah. So like people who have serious wounds, right? Especially burns, depending on, you know, the level of burn. You know, the horrible thing about burn patients is they go in and they literally scrub off the dead tissue. Because it's dead. We cannot, when it's dead, we cannot repair it, right? We can't replace it. Well, you know, your body can't, but we can, right? Skin grafts and things like that. So the problem with that is once it's dead, right, and especially when you have destruction to the blood vessels, we can't get the white blood cells there to even clean up the mess. So we've got to remove it. Otherwise, it's just a cesspool for organisms to grow and eat, right, and possibly infect the rest of your body, right? So that's where people, you know, end up with, you know, my husband, you know, if they couldn't clear up that infection, he was going to lose his leg, the lower part of his leg, because of that. Because the thing is once it's dead, right, like I said, we can't replace it. And we got to get rid of it because then it's just a source for stuff to grow, right? And spread to the rest of the body. So that's the main reason why they do amputation, is because it can't recover it, right? It's been destroyed to that level that we can't repair it.
So that's what the maggots are doing?
So what the maggots are doing is they're eating away the dead tissue. Yeah. When they do maggot therapy, they're eating away the dead tissue. Right. So, yeah. Yeah. Yeah, I couldn't imagine having to do something like that. But even still, you know, like I said, you know, if we can't get blood flow to that area, your body can't clean that up. So we've got to remove that dead tissue. Otherwise, it's a liability, a serious liability. You okay?
When that process is going on, are they awake?
Huh?
When that process is going on, are they awake or yes?
Oh, it depends. I don't know whether the person is awake or asleep when they remove stuff. I mean, in the case of my husband's surgery with the dead tissue, he was definitely knocked out. But I don't know about burn patients. I don't know if they can. Yeah. Yeah. Oh, that's what I'm saying. So she know you've seen it. Yeah. So, yeah, they got to do it right away. And the other thing, too, is depending on how the extent, like you don't want to knock the person out and them not wake back up. you know. So yeah, that's what's so horrible about it, is that they're literally scrubbing you and you're alive, you're awake. Well, you're glad you're alive, but you're awake, yeah.
It seems like they want to be able to feel it because of like nerve damage.
They feel it. They feel it because it doesn't all get damaged. If it gets damaged that severe, boy, you're lucky to be alive. If you're alive. Yeah. So, okay, so let's get off that one. Scary stuff. So autoimmune, what does that mean? Auto means self. And again, this important distinction of self and non-self. Unfortunately, and this is one objective you don't have to worry about on the test, right? I'm not going to have you give, it's a multiple choice, right? Matching true and false test like before, right? Having you give examples is not possible, right? No short answer. Does that make sense to you guys? Right, okay. But we're going to go over some examples because this really helps in our understanding, right? But I don't expect you to memorize these and regurgitate them back to me, okay? I used to do short answers on my tests. No one has complained about them being gone. Okay, so what happens? The body usually recognizes self-antigens, right? So we know us. So in this case, we're not recognizing, right? We're not recognizing ourselves. We're seeing ourselves as foreign, and so therefore we're attacking ourselves. So destroy cells that would destroy self. Normally, right, it's that weeding out process that happens in our bone marrow for our B cells and our T cells in the thymus, right? We're going to eliminate any of those cells that recognize self. Does that make sense? So, what happens if one of those escapes? So what happens if we have a B cell that produces antibodies against our own antigens?
That's going to start spreading to the other to that cell, right?
Well, what's a B cell do? It produces antibodies. But in this case, they're antibodies against us, right? So this is autoimmune, right? This is a problem. So there are certain malfunctions that can happen in the immune system. That's why we have the existence of autoimmune disease. So one of them, right, autoimmune diseases may result from reactions to antigens that are similar to MHC self-antigens. So remember, MHC, right, in the beginning, they were the ones that was creating this problem with transplants, right? Now we know, right, that it is a communication molecule for our immune system, right? But anything that's seen as foreign is referred to as an antigen, right? Self-antigens, right, is referring to stuff that's us. And that's kind of confusing, right, when they say self-antigen, because antigen means something foreign. But they're also meaning in that instance anything that the immune system makes a response to. Remember we talked about, you know, the most common response for an antigen is an antibody that we can easily detect. But cytotoxic T cells are an immunological response to foreign things too, to antigens. Okay? So antigen has a kind of twofold definition. It's something foreign, right, that our immune system responds to. But, you know, it's an immune system response, right, when something is foreign. The problem is that sometimes our own molecules are considered foreign by our immune system. In that case, we're experiencing autoimmune, right? We start attacking ourselves. So our MHCs, very interestingly, remember when we talked about ABO blood type and about how you get exposed to stuff other than that have those similar antigens, right? So there are bacteria and stuff out there that we naturally get exposed to. that have antigens on them that are very similar to the antigens on our red blood cells, very similar to A and B. So you become what we refer to as naturally immunized, right? Naturally exposed, naturally produce these antibodies that if you get a blood transfusion of the wrong type in that group, chances are you're going to have a reaction, even though you've never had a blood transfusion before. Different with RH, though. RH is a pretty unique antigen, and pretty much the only way you get exposed to that one is if you get positive blood, if you get exposed to positive blood. And for women, there's that added risk of pregnancy, right, that we could get exposed through pregnancy to a positive child thanks to our husband if they donate a positive, right, allele genetic information. So with some autoimmune, they found too that there are maybe some bacteria or antigens out there, pathogens, that have antigens on them that are similar to our MHCs. So much so that unfortunately, right, we might produce antibodies or a response to something that's so similar to our MHC that we end up attacking ourselves. Does that make sense? Right. So there's, and that's probably beneficial to them to a certain extent, right? To kind of look like self. Because for some people, right, it may look so much like ours that those B cells and those T cells get deleted. So we don't produce antibodies against this pathogen because it looks like us, you see? And so that's beneficial to them, evolutionary-wise, to look similar to us, because then maybe they can escape detection by our immune system. It's triple bad news for us, because if we do mount a response, it might be so similar to us that we then not only are attacking the pathogen, but we're attacking ourselves now.
So that's what's happening with that.
Yeah, with rheumatoid arthritis, certain forms of rheumatoid arthritis, it's where the person is attacking their own joints. They've made antibodies or even have cytotoxic T cells that are attacking their own joints. So again, too, a lot of the therapies for rheumatoid arthritis are immunosuppressive. But that puts you at risk for other things, right? But, you know, what do you want to deal with? The fact that you can't move your joints anymore? Or that you might be more susceptible now to infection, right? It's kind of a trade-off. So the other thing, too, is that some of your organs are somewhat immunological protected, where your immune system pretty much doesn't really go there anyways. So the problem is, too, is when you have injury, then your immune system goes there, right, because we have injury. And so then we get exposed to these things that we normally should get exposed to, our own tissues, that we've probably not deleted those cells, and so then we start attacking self, right? They've seen that in certain instances, right, where we've had injury, and because of that influx, we've gotten exposure to that area that we normally wouldn't go, right? So our system is pretty awesome, right, of protection, but there is definitely things that could go wrong. It's not a perfect system, right? Just like with our computers, right? Even they get sick, right? And so the thing is, too, is like what we've been saying is, why do we still get sick? Because organisms have found these tricks and ways around our system, right? There are ones that can avoid detection by antibodies because of having a capsule that isn't very immunogenic, right? That we're not very easily detect them, right? That's where vaccination helps us out with some of these ones with those special capsules, right? We expose the people ahead of time to this information so that we can produce antibodies against these capsules and detect those guys. You know, we have ones that can escape phagocytosis, right? That can grow inside of our macrophages, right? That's pretty scary stuff, right? But that's why we still have these diseases, why we still get sick, right? Because for a certain time period, at least, they can evade our immune system. And some of them can do it to the extent that they cause death of the individual, right? That's what's so scary about these viruses and these pathogens. And especially when it comes to viruses, we have very little drugs out there that are antiviral, that are effective against viruses. So what are you relying on to get rid of that virus? Your immune system, right? Which is why rest, right, fluids, still eat if you can, is very important, because you got to support that army that's hopefully going to save your ass, right? Your immune cells, those natural killer cells, your cytotoxic T cells, right? You want to give them everything they can to get the job done. With bacteria, though, for a lot of those, we have what type of treatment? Antibiotics, right? We have antibiotic treatment. But even with that, right, you've got to catch these things early when we don't have a lot of destruction to tissue, right? Because how do the antibiotics get there? Through your blood, right? If you have destruction of blood vessels and a lot of dead tissue, it's not going to get there.
I have a question. So what about something like pink eye? Like my daughter had pink eye 2 weeks ago.
Mm-hmm.
They sent her home yesterday. She had pink eye.
Mm-hmm. So pink eye is an infection of the conjunctiva of your eyes, right? Bacteria can cause it, so can viruses. So with a bacterial infection, again, they can give you ointments and stuff that will help. They'll still usually give you ointments and sometimes even antibiotic eye drops if it's viral, because you want to make sure that you don't get secondary infection while your body's taking care of the virus. The problem with that is highly infectious, and like I said, it can be caused by multiple viruses, multiple bacteria. So you can get an infection back to back like that, especially if wherever she picked it up from didn't get cleaned. Yes. Yes. And this is why it's very important to never touch your eyes, right, with your hands, unless you absolutely have to. And if you do, if you can, wash your hands first, because you don't know what's on your hands. And it's so hard to, like, the minute you talk about that, like, you're like, you want to rub your eyes. Don't do it with your hands, like, you know, elbow, something else, right?
Is your son a germaphobe?
Huh?
Yes, son. Is he a germaphobe?
No, just me. And I'm not even that bad. But when it comes to certain things, like, you know the risk, right? And so, yeah, you're going to do the best you can to not expose yourself. So, yeah, my son got pink eye when he was in daycare. You know, it happens. But that's also why they'll send him home, because I don't want, you know, them getting anyone else, because little kids don't know proper hygiene. Like I said, daycare, there's a bunch of little germ magnets running around. Little kids, they just don't know yet, right? We have to teach them, right? We have to teach them. It's one of those things you have to. No memory cells for pink eye. I mean, yes, maybe if it was the same bacteria,
So
but different bacteria or different virus, right? So, yeah, it sucks. Okay, so for autoimmune, right, type 1 diabetes, which usually happens early in life for individuals that have this, and this is one of those defects at a genetic level where their T cells don't recognize their beta cells as self, so they destroy them. The problem is the beta cells make what? Insulin. The beta cells in your pancreas make insulin. So you just wiped out all the cells that make insulin. Insulin's a little bit important because insulin tells your cells, I don't know why they need this, but they need it, that glucose, sugar, is available for them to eat, right? Without that signal, they don't know it's there. They don't take it in, they don't utilize it. So then they utilize other things like proteins, and they produce acidic byproducts from that type of digestion, right, which can be extremely life-threatening when your body goes too acidic, right? This is diabetic ketoacidosis, right? Can be very damaging, where they'll slip into a coma and die, right? So the good news with this is, what can we do for diabetics that can't produce their own insulin? We give them insulin. Right? We give them insulin. And thanks to biotechnology and stuff nowadays, we can make bacteria make human insulin. It looks just like human stuff. So we don't have to take it from other animals. We don't have to worry about people having cross-reactivity. So the insulin that they take actually was made by a bacteria, but it looks exactly like the protein that humans make. And it's a protein. That's why it has to be injected, and you can't take a pill, because your body would just digest it as if it was a protein. We don't need it digested. We need it in its whole form. It's actually, I think, 4 proteins hooked together. So that's why they're trying to develop like nasal things where they could maybe go through their mucous membranes and enter the bloodstream. They've still been working on that. And then the really awesome thing is, because of proteins and heat can affect them, most diabetics would have to keep it refrigerated, their insulin. Again, they've kind of tweaked, biotechnology-wise, tweaked the molecular structure of that protein so that it's more stable at warmer temperatures, but yet still is not recognized as foreign by the immune system. It's still human insulin, but it's been slightly tweaked so that it's more stable at higher temperatures. So it doesn't have to be refrigerated. So it's pretty cool stuff that we've been able to do with that.
You said cross, and you're talking about getting insulin from, like, you say, other animals or something. What could be a possible reaction if people were to still be doing that and someone would have a reaction to it? What would be? Well,
it's a reaction where your immune system is recognizing it as foreign. So probably you're getting antibody production, right? Oh. So and then again too, your immune system, right? If it recognizes that protein as foreign, just like people who are allergic to penicillin, right? It's recognizing as foreign. The bad news about that is the immune system is going to bind to it, eliminate it, and it's not going to be present to do what it needs to do. So, if you have an allergic reaction to insulin, again, it's pulling it out, attacking it, and it's not available to do its job. Make sense? So the other thing with Graves' disease, this is autoantibodies that are binding to the thyroid-stimulating hormone receptors. So you have hormone receptors, right, that the hormones bind to and tells your thyroid to make thyroid hormones, right? And these are very important to your metabolic balance in your body. Well, in this case, it's getting overstimulated because the antibodies are binding to the receptors, and that binding is sufficient to get the cells to produce the hormones. So you get hyperthyroidism, right? You produce too much of the hormone, even to the point where it will swell. Well, the problem with that, too, is that now the thyroid is not doing its job, right? It's not doing it accurately because the immune system is triggering it instead of your endocrine system. So what do they have to do for those individuals? They have to take medicine, but before that, they got to remove the thyroid. Right, they got to remove it because it's not doing its job. Right, so they remove the thyroid, and then again they're on supplement thyroid therapy for the rest of their lives. Right, so my best friend had a tumor on her. It was a different situation. Right, for her thyroid, they had to remove it, and now she's on replacement therapy for the rest of her life.
I have to take medicine.
You have to take medicine because yours is not working properly. You didn't have yours removed though. No, yeah, but not working properly. Yeah. And it can go either way, like not producing enough, which is probably your case, right? Where if it was a hyper situation, yeah, hyper is producing too much, right? Which what happens in this condition, hypo is not producing enough. So usually people who are hypo, which is probably your situation, you're not producing enough, you have to take supplemental therapy, right? Okay, so some of these attacks can be relatively specific, as we've talked about with these two examples. Other ones, right, again, somewhat specific but more widespread, right? So myasthenia gravis is specifically dealing with, am I running out? Running out of time. Yeah, so these aren't going to be on your test. So I'm going to skip over it, but this is kind of cool stuff. Okay. So we've already talked about some of the therapies. I want to get to the 2 immunodeficiencies, though, because these are important. So there's 2 types of immunodeficiency. There's primary or congenital. This is something you're born with, result of a genetic defect or a developmental abnormality, right, as you're developing. Secondary or acquired is what most of us are familiar with, right, and this can be a result of infection or another stressor, right? So the most common infection we know about that debilitates the immune system, good old HIV, which stands for Human Immunodeficiency Virus. So this virus specifically attacks your helper T cells. It binds to your CD4 on those helper T cells and infects those cells. So it seriously debilitates those helper T cells, which for B cells, sometimes we need those, right, to produce antibodies. So it can significantly reduce your antibody production and your ability of helping your macrophages and their activation as well. Doesn't affect your cytotoxic T cells. But, you know, humoral antibody immunity is very important, right, to our adaptive immune response. So AIDS actually stands for Acquired Immunodeficiency Syndrome, because at one time they didn't know what was causing it. So there are people, though, because of the drugs and stuff we have now, stay at HIV status and don't progress to AIDS. AIDS is bad because at that point your immune system is deficient, right? And so if you get another infection, you can't combat against it. So you guys know the most common cause of death for AIDS patients? Pneumonia. Pneumonia, right? So they get that other infection, they can't defend, it kills them, right? So, but other things can cause your immune system to be deficient. Syphilis can overwhelm your immune system, so much so that you become deficient. And again, it's going to be a secondary infection that gets you. Leprosy can be overwhelming. If you don't eat, right, malnutrition, remember, you got to support that army. If you can't support that army, it's going to be deficient. As we age, right, we just can't maintain that army. Right? You can become immunodeficient. Malignancies, right? Other things going on that are pulling away from your main source of your army. So now I'm going to back up to some of the genetic primary ones. So for primary, right, again, these are relatively rare. So for selective IgA deficiency, this is where individuals, right, they don't get that signaling to make that switch to IgA. Remember, where is IgA found? In your mucus, right? Your tears, your saliva, right? It's that type of defense. So it's the most common disorder, about 1 in 333 to 700. But that's one small component of your immune system. But think about this. If you're not producing IgA or not a lot of it, what type of infections are you going to be more prone to? Respiratory, right? And digestive, right? And even, you know, nasal type stuff, right? Because that's that protection that you don't have, right? So some people, again, fewer no antibodies. That's worse, right? But although relatively rare, I've ran into one of my students in the past, her daughter had it. And so she had to go and get injections of immunoglobulins from other people. So remember, too, my little plug, and especially with Halloween coming up, for those of you guys that like that kind of stuff, the mortuary always pairs up with the blood center. And if you donate blood, you can get free VIP passes to the mortuary, that haunted house thing. I'll pass on that. But, you know, if that's enough to encourage you to donate blood, then please go do that. Because you save lives in multiple ways when you donate blood, right? They use your red blood cells. They pack the red blood cells. But, like, your antibodies, especially against stuff you've been vaccinated, can help individuals who can't make antibodies, right? So they divide that up, and they can save as many as 5 people, right? Help out 5 people with your 1 pint donation. So if you can do, right, it really, really helps. Okay, so that's it for this. Make sure you do your Connect assignments, right? And make sure you check Canvas, because we may have to change test location. I'll put a sign here too that day in case you come here. Let me